about spine anatomy and how we can relate spine anatomy to trauma. So, it's not working. So, since we have quite a lot of presenters, we are going to keep our spine anatomy pretty bite-sized, and we're going to highlight on certain really important things. Now, I find spine to be a really beautiful structure. It's a massive, massive structure, and there are about 60,000 species here in this world with a vertebrae. And among them, humans are one of the few bipedal species able to stand on our 2 feet, and our spine has very unique biomechanics compared to other species, and that enables us to function the way we are. So we are going to highlight on this is a general overview of the human spine. There are about 33 vertebral bodies, about C5 up until about C7 and T12 and L5 and fused sacral vertebrae. And there are about 4 curvatures, and we are going to also learn about how these curvatures actually play a role in stabilizing the spine. And there are a lot of important structures that surround the spine that's related to it. I've just put an MRI sagittal section just for comparison. So now coming down to cervical spine biomechanics and anatomy. So I find cervical spine to be the most unique set of all, actually, because there are a lot of morphological changes compared to the other cervical, thoracic or lumbar vertebral bodies. So in cervical C-spine, which is also known as the Atlas, basically named after the Greek god that carries the planet on his shoulders, Atlas lacks a body. Basically, there's a large foramen and lateral masses. While you have the axis, and the axis, what's unique about it is that there's a dense, basically a large projection that goes up superiorly, and like a divorced portion of the C1 vertebrae. So we're going to learn also how it collaborates with the C1 in movement. Now from C2 down to C6, what's unique about that is the spinous process is bifid, like a small little heart. And C7, also known as vertebral prominence, namely it's an anatomical landmark which you can palpate, also used preoperatively for surgical marking as well. So cervical spine, there's few functional units, namely for the cradle, based on the movement of the occipital condyle with the C1 or the Atlas. And then you have the axis, basically how the C2 or the second cervical vertebrae collaborates with C1, and then you have the root, how C2 and C3 collaborates. You have the column, basically the rest of the cervical vertebrae, how it collaborates. Now coming down to basic biomechanics, we're not going to dive so much in depth into this. So C1 basically acts like a saddle joint, causal joint, basically with flexion and extension movement with limited restricted axial movements. And that's where C2 comes in. As I have mentioned earlier, C2 has a dens that projects, and the dens allows, like a pivot, the C1 to rotate in axial form. So when it comes to certain mechanism of trauma, which we'll learn later during the CME, we will also understand how that brings about fractures. So C-spine has flexion, extension, and axial rotation. So now coming down to anatomy and biomechanics of the thoracic spine. Now this is a pretty rigid part of the human vertebrae. There are a lot of important structures in the posterior mediastinum, namely the descending aorta, a vagus nerve, esophagus as well, running anteriorly to the spine. So thoracic vertebrae, what sets it apart from the rest of the vertebral bodies are that there is costovertebral joints. You can see the facets which basically articulates with the ribs. All the ribs articulates with all 12 thoracic vertebrae. So the thoracic vertebrae, what's special about them is as it goes down, it becomes bigger in size, and there's special functions of the articulation of the ribs. So how is the thoracic spine stabilized? Such a massive structure. So we are going to think about the ligaments, which we'll dive a little bit later down the presentation, and also the costovertebral, the joints there. So what these joints does is not only assist in breathing with its pump handle and bucket handle movements of the chest wall, it also it becomes a very rigid structure, providing posterior stabilization as well as anterior stabilization. And the sternum itself, although indirectly, acts as a shock absorber So we have a CT axial cut where you can see the costovertebral joints. And so it's important in trauma to identify this section because in rib fracture, whenever there's a rib fracture associated, we have to also think about the dorsal spine. So now coming down to the anatomy and biomechanics of the lumbar spine, this is one of my favorite sections of the human vertebrae. So lumbar vertebrae is massive. Even the disc spaces become huge compared to the cervical spine and the thoracic spine. Namely this because of how it spreads down the moment or the Newton force down the spine, how it spreads down. So how it distributes the force basically. So the vertebral body becomes larger in size, the discs become larger as well. Discs act as a powerful shock absorber, basically absorbing water as a hydrophilic component. And there's, the ligaments also is tougher compared to the thoracic or the cervical region. So just to show, we have a sagittal section of the lumbar sacral spine. Just to highlight on the ligaments, basically you have about 6 or 5 ligaments, anterior, posterior, with ligamentum flavum and supraspinous and interspinous ligaments. So now coming down to the most important giveaway from this spine anatomy and biomechanics is the Dennis-Ferguson column theory. So this column theory was actually brought forward in a few research articles as well, and it doesn't necessarily highlight a way that you can diagnose a condition, but rather helps in classification, helps in identifying what structures or the stability of the spine is involved. So basically, your anterior column, your 2/3 and 1/3 is consisting of the vertebral body, which transmits majority of the compression forces, while your posterior aspect, which is your spinous process and the posterior ligamentum complex and the pedicles and the lamina, helps in prevention of sudden buckling movements when it comes to trauma. So it's important to learn the DF column theory when it comes to spine trauma. So that concludes my short presentation on spine anatomy. Thank you.